Can we go live?
You're live now, sir. You can start.
Arun?
Sure, I'll start, sir.
Yeah, okay.
Good morning, everyone. Myself, Arun Kumar from Chennai, here to discuss on the role of point of care ultrasound in de-resuscitation. We know the current concept of modern fluid resuscitation emphasizes on the concept of goal-directed fluid therapy, optimizing the stroke volume, cardiac output, positive pressure, pulse pressure variation, stroke volume variation. So, regardless of the monitoring device, so the foundational aspect is that the patient should receive plasma volume only if there is the recorded fluid responsiveness. So this is just to highlight the importance of the today's concept of discussion, the de-resuscitation, because if you can understand, the endothelium is a tightly linked barrier that maintains the intravascular space via gap junctions. So yet through microvasculature, there occurs a leak of plasma proteins. But under physiological stress and under sepsis, what happens is that these gap junctions get loosened up. And it is shown that even in healthy hypovolemic subjects, only 40% of the fluid bolus which we give as a part of resuscitation stays in the vasculature after 15 minutes. So this study is performed in 2003. What they did, they attempted in healthy volunteers, they attempted or induced hypovolemia by removing around 900 ml of blood and replaced by colloids and crystalloids. And they found that only 40% of whatever the infused fluid remains in the vasculature at the end of 15 minutes. So if you see in stressful conditions, secondary to these gaps, the fluid which remain in the intravascular space is going to be further less. So further necessitating fluid resuscitation, and this comes as a vicious cycle. So at one point of time, we'll eventually land up in a fluid overload state. So what happens in these states will further lead to a capillary leak, a set of capillary leak syndrome. So it is prudent for us to understand when to start fluids and when to stop fluids, when to start fluid removal and when to stop fluid removal. Of which the last two entities constitute the de-resuscitation part of the concept, and this eventually is what is referred to as fluid stewardship. So coming to the today's discussion, de-resuscitation. So not going into the details of the ROSE concept. So de-resuscitation comes into a picture in the towards the end of the ROSE model, the stabilization phase and the evacuation phase. So in other words, late conservative fluid management and late goal-directed fluid removal is what constitutes the de-resuscitation. So again, this is important because it is shown that fluid accumulation syndrome is a starting point of de-resuscitation, and every attempt during resuscitation should be taken care of not to achieve a state of fluid accumulation, or rather to prevent fluid accumulation syndrome. So, till date, there is no formal definition of fluid resuscitation syndrome, or how to go about with the like how we have guidelines for resuscitation programs. We don't have how to de-resuscitate these patients. So this is a paper taken published last year. So they define fluid accumulation syndrome as, so any patient with a cumulative positive fluid balance, say more than 2 liters, with any organ injury, is what defined as fluid accumulation syndrome. So taking this as a for discussion sake as a formal definition, so we can see the ways to recognize fluid accumulation syndrome as clinical examination, any anasarca or any evidence of fluid overload like ascites, effusion by ultrasound, X-ray, advanced cardiac output monitoring like PICO, volume view, looking for EBLW and PVPI, and bioimpedance analysis. So bioelectrical impedance analysis and advanced cardiac monitoring tools are not always widely available. Chest X-rays are not again consistent to show or denote a fluid overload state always. And clinical examination, again, they have a high inter-observation variability. And to some extent, though we have inter-observer variability, a focused ultrasound is a kind of reliable tool in these settings. So again, for practical utility, recently published a radar trial, they used as an inclusion criteria of fluid balance of more than 2 liters positive, or any evidence of edema in more than one anatomical site. The slight modification from the formal definition of the fluid accumulation syndrome, which I told earlier, they used this criteria to label the patient as fluid overload. So coming to topic proper, utility of ultrasound in deresuscitation. So we'll go system wise. First, coming to the cardiac focused ultrasound to the left ventricle. First, we have the left ventricular outflow tract VTI. So to calculate LVOT VTI, we go to the apical five-chamber view, place a pulse wave Doppler at the LVOT and activate the pulse wave Doppler, and the right hand side of the panel and trace around the ejection wave, and we can record the VTI in centimeter. Usually, this is done after a fluid bolus. If after a mini fluid challenge, because why mini fluid challenge? Because already we have loaded the patient with fluid during resuscitation. If the patient is not fluid responsive anymore, which implies we all know the patient is lying in the flat portion of the Frank-Starling curve, and there is no point in giving fluids. And given the concerns with the clinical assessment also, so we can label the patient to be potentially the patient to be on or going towards the trend of fluid overload, and we have to attempt a deresuscitation at this point of time. So otherwise, instead of calculating the VT directly, we can put a pulse wave and look at the swings of the pattern of the LVOT. If there are no cross swings, like here we can see the A and B and the A prime and B prime, we can have wide swings, and which means we can like eyeballing, we can say that this patient is fluid responsive, and then there is no major swings like this, we can label the patient to be fluid unresponsive. And given the clinical context, I think it's prudent to start deresuscitation at this point of time. Second, the diastolic assessment, we have the E by A ratio. So very low E by A ratio and very high E by A ratio is again detrimental to the patient. So E by A ratio of less than 0.8 denotes a impact relaxation, and which means that we can't give more and more of fluids to them. So, and similarly, E by A ratio of more than 1.8 denotes a restricted filling, and we can't give more fluids again. So this mitral valve inflow velocity has to be taken over a series of measurements, because this is not a one-time testing, and one-time testing doesn't give any clue. Maybe it can say that whether we have to restrict on fluids right from the point of resuscitation given the underlying cardiac condition, but whether to start deresuscitation or not, the trend of the change of the mitral wave velocity can give us a clue whether to go to the either direction, whether to give more fluids or we can restrict on fluids, or if the patient initially was on grade 1, now progressing to grade 3, maybe over a period of days, maybe we should think that we need to attempt deresuscitation in this group of patients. So again, we have another concept of MAPC, but it's not well supported for deresuscitation. So coming next to LV end diastolic area. So the LV end diastolic area is measured at the level of mid-papillary level of the left parasternal short axis view. So usually 10 centimeter is taken as the cutoff. Anything so more than 10 centimeter denotes the LV size is getting bigger. And second, this has to be always coupled with the other dynamic indices, because this cannot be taken as a solitude measurement. And moreover, again, like how we discussed for the diastolic assessment, a one-time measurement of the LV and diastolic area doesn't give any clue. Again, a series of measurements should give us a guide on how to go about the fluid management. So coming to the right ventricular assessment. So first, looking at the size of the right ventricle, we have the RV by LV end diastolic ratio. So if the ratio is more than 0.6, which means we are putting more load towards the right side of the heart. And if the trend of the RV by LV ratio is on the rising trend, which means probably we are straining the heart and we need to limit on the fluids. And if it's time, we need to start attempt deresuscitation at this point of time. Again, it's a TAPSI. At the fourth chamber view, go to the tricuspid annulus and put a pulse wave Doppler, and we can measure the TAPSI. And if the TAPSI is less than 1.7, so taken as a cutoff, taken as less than 1.7, which means the right ventricular performance is again low. And again, this has to be taken over a series of measurements compared with the baseline levels. Coming to the X-wave measurement, to place a cursor over the lateral annulus of the tricuspid valve and put a pulse Doppler in the. And here, I mean, you need to decrease the gains for to avoid measuring the noise artifacts, and whatever the velocity which is positive, that's above the baseline, is taken as the S wave velocity. So the higher the velocity, the higher the right ventricular function is. So again, S wave has to be taken with in comparison with the baseline. So a solitude measurement will not help in deresuscitating this group of patients. So this is with the focused echocardiographic measurements, but out of which the most commonly used entities which can be used are TAPSE, and the left ventricular assessment can be usually and easily used at the bedside. Second, coming to the assessment of vasculature, so IVC measurement. So though even for fluid resuscitation, the static indices are no longer in use. Maybe just to guide the optimal timing for deresuscitation, the IVC measurement can give us a clue whether to initiate deresuscitation at a time frame. So if IVC is more than 2 centimeters, so given the patient looks clinically overloaded, maybe at this point of time we can consider, or the patient is developing AKI, new onset AKI. At this point of time, we might consider that this patient might landing up into fluid accumulation syndrome, and we can attempt deresuscitation measures. So this along with so rather than the value of IVC diameter, we can look at the IVC collapsibility in spontaneously breathing patient, and so we can see the collapsibility index by taking the maximum diameter minus the minimum diameter divided by the maximum diameter, and we can see the collapsibility index, the pattern of the collapsibility index at the from the point of resuscitation to the current point, whether to initiate deresuscitation or not. So otherwise, we can correlate with the IVC size and the CVP. Again, CVP is again a poor marker for resuscitation also, and I think the same will hold good for deresuscitation as well. So not going by the CVP and IVC, rather we can look into the IVC collapsibility and distendability index in case of mechanically ventilated patients. So of more interest in the recent days, the hepatic vein Doppler, the portal vein Doppler, and the Texas scoring. So the hepatic vein Doppler, so we can see the S wave and the D waves in the hepatic vein. So usually the S wave has a more negative reflection than the more negativity than the D wave. And when this ratio is getting reversed, the hepatic I would say the congestion is ongoing. And when we see that the reversal of the flow means the positivity in the S wave and the negative deflection in the D wave, which means there is severe congestion, and it is the time for us to remove the fluid judiciously. So a slight extension to the Vexus scoring. So if the IVC is a prerequisite to initiate the Vexus scanning, so if IVC is less than 2 centimeters and there is no congestion, we can label the patient as grade 0. And for grade 1, there should be IVC of more than 2 to label the patient from the grades with any combination of hepatic vein or portal vein or intra-renal abnormality. So a normal hepatic vein, portal vein, and intra-renal ultrasound with a dilated IVC labels the patient as grade 1 or mild congestion. So IVC of more than 2 and at least one of the abnormality in the hepatic vein or portal vein or the renal vasculature will labels the patient as grade 2. So the hepatic vein we just discussed. Normally a portal vein, usually the pulsatility of the portal vein is less than 30% is taken as normal, and if anything is more than that is taken as abnormal. Similar, just like a hepatic vein, a reversal of the S and D pattern even in the renal vasculature can uh, can define the grades of the excess scoring. So this is taken from the supplementary copy of the IJCCM last year critical. So they studied the effectiveness of deresuscitation with Vexus along with the standard protocols. Standard protocol, they say, based on the clinical assessment and the echocardiographic assessment. And they compared this with Vexus, and they found that those patients who are categorized into the Vexus group, they have demonstrated significant reduction in the cumulative fluid balance on day 3 and day 5. So coming next to the lung ultrasound, which is most commonly performed for assessing the fluid status in critically ill patients. So, not going into the details, finding a B profiling or worsening B profiling in the routine day-to-day ultrasound maybe categorize a patient that the patient is a likely fluid overload and we have to attempt a resuscitation. So next, the lung aeration score can be done. Again, this is not a one-point testing. So a series of lung aeration score and together with the clinical context, because they should not confound with the underlying the lung picture. So a clinically overloaded patient with a poor aeration reflected by the worsening lung aeration score maybe defines the patient is landing up into pulmonary edema or a fluid overload state, and we have to attempt the resuscitation. This has to be always complemented with the echo findings and other clinical measures. So this study is ongoing. Ultrasound guided fluid resuscitation on intense critically ill patients who are on ventilator. The confidence study. This is still ongoing. They use the lung ultrasound parameters, especially the lung aeration score, to guide the resuscitation. So again, this is the sample algorithm I could find. So using lung ultrasound along with the IVC. So when the IVC is underfilled, so they comfortably say the patient we can to resuscitate the patient, and if the IVC is distended, so it is they say to restrict the fluids. But just by looking at the 1 point value of the IVC, whether we can advocate or restrict fluid is one thing to discuss upon. Second, looking at the lung, if this is if it is equivocal, it's time to look into the lung ultrasound. And if looking at the pattern of A lines and B lines and the B profiling, we can guide the further fluids for this group of patients. So coming to the last part, the abdominal ultrasound. So we have the renal resistivity index. So we go to the sorry. So I play the cursor over the interrenal artery, the arcuate of the the interlobar one. So under the color Doppler guidance and the spectral analysis, the signals are obtained, and the systolic peak and the diastolic peak are then measured. So RRI is calculated using the peak systolic velocity minus the lowest diastolic velocity divided by the peak velocity. So we can see the higher the RRI, the high which reflects the higher the resistance for the renal vasculature, and which means the higher the progression to congestion. So again, so when resuscitating a fluid, I think we need to look at the basal value of the RRI, and we need to measure at frequent intervals, maybe at every 24 to 48 hours, or depending upon the clinical context, and to look at that, because congestion alone doesn't reflect RRI, because they have a multitude of confounders. So looking at the pattern of RRI from the baseline after resuscitation, and it might give a maybe a earlier guide to initiate when to initiate the resuscitation in this group of patients, critically ill patients. So the last aspect, and we all know, secondary to the fluid creep and the extravasation into the third space, maybe the development of new onset ascites after resuscitation maybe indicates the patient is landing up into a fluid accumulation syndrome, and we need to not to miss the abdominal ultrasound along with the routine point of care ultrasound during our routine assessments in our day-to-day ICU. So to conclude, so to always to consider IV fluids as drugs, so not to forget fluid stewardship, and to as how resuscitation is an important cornerstone in managing critically ill patients, it is prudent to understand that even de-resuscitation is equally important, which is often overlooked upon. So attempts to de-resuscitation should be taken in a more a programmed way, and more RCTs are yet required, because just we have so many guidelines on how to go around with the resuscitation policies. We don't have a hard and fast guidelines how to de-resuscitate a patient. So though we have the guides of when to start, we don't have a stipulated time frame of on when to start de-resuscitation also. So more RCTs are required on this aspect. And I would like to conclude with this quote: IV fluids are drugs with indications and side effects. If used without clear justification, they may be the most frequently administered nephrotoxic agents in hospitals today, and especially the ICUs today. Thank you.
Thank you, Arun. I think you have very crisply and succinctly covered the entire.
Srinivas, your voice is hello.
Sir,
Srinivas, we can't hear you.
Therapy and start the process of de-resuscitation either pharmacologically or extracorporeally. So we basically are looking at the IVC, the distensibility, then of course upstream you look at the other veins and then you decide whether there is systemic venous congestion or not. But this has also always has to be coupled with a clinical review, a chart review, and of course combination with lung ultrasound. We cannot do it without a lung ultrasound. The important aspect of de-resuscitation is that we should not just get carried away by one number. Just don't look at the IVC and then say everything is fine. Look at the other aspects of the venous system also and understand where the fluid overload is happening. A note of caution, every patient who tests high on the VEXA score is not always a candidate for de-resuscitation. There may be other entities which are causing venous congestion like venous occlusion or other diseases. So the caveats for the interpretation of VEXA should be understood before we um, act upon the results of the VEXA score alone. That's all I have to say. Thank you.
Uh, Thank you, Arun, and thank you, Dr. Thank you, Srinivas. See, I think over the last few years, our understanding of the role of fluid in intensive care has changed very, very significantly. I distinctly remember when we were fellows, we used to pump in fluid whenever we used to get a sick patient. We used to just keep on pumping fluid. Now, from that point, we have come to a point where we are very, very judicious about every time we think of giving a fluid. So, for me, de-resuscitation starts from the first step of resuscitation. Avoiding over-resuscitation is probably the first step for de-resuscitation. And, always look for a clinical indication. As Srinivas said, just because something or the ultrasound shows or something, some of your numbers are abnormal, doesn't mean that you start acting. Until and unless there is a clinical indication or reason, probably we should not, actively try to draw out fluid. Because there are only two known techniques. One is either by giving diuretics or by giving your extracorporeal therapies. And not every therapy is always safe. It has its own consequences. So yes, keep a watch on what's happening with your fluids. Keep a watch on what's happening with your fluid overload status. That is not good. We know that it's going to be bad. At the same time, just because you have a device in your hand and you can measure some amount of fluid overload doesn't mean that you start actively removing fluid. So always look at the clinical picture and a clinical need for removing fluid, and try to look at the safest way of removing the fluid in your given patient. Thank you.
So thank you all for joining us. Please do subscribe to the Hicks YouTube and be in touch. Watch this group for another program next week on an important topic in critical care. Thank you all and have a good day. Bye bye.
Thank you.